अल्ट्रासाउंड वेयर वी नो कॉमनली अल्ट्रासाउंड इज माता का पेट का स्कैन करना है क्योंकि बच्चे का अंदर का वेलबींग देखना है. सो इट इज लाइक फॉर नोइंग द फीटल वेलबींग वी स्कैन द मदर, बट एट द सेम टाइम एक्सरेज आर हार्मफुल. So that was again a piezoelectric crystal was the first thing. So that is a piezoelectric crystal where it actually takes up electrical energy, creates vibrations. Those vibrations are transmitted to the body. Then the reflections are coming up, and then you form an image.
So you have seen hundreds of topper passing from this AIIMS Raipur. What is one non-academic quality which separates a brilliant student from a legendary doctor?
In medical field, perseverance, if it is combined with compassion, आस्था जो मरीज के लिए होनी चाहिए, वो compassion अगर lacking है, तो you may be a good doctor, a good student, आपके पास knowledge बहुत है, और मरीज का ट्रीटमेंट जो है, मरीज को चॉइस दिया जाए, शायद आपके पास नहीं है.
Sir, if someone is watching this and does not have any idea about you, how would you like to introduce him about yourself?
Oh, this is interesting. ये तो ऐसा हो गया कि मैं कैसा अच्छा आदमी हूँ वही बताना पड़ेगा. So I would like to put this in the view of your channel like a masala chai, है ना? The optimum blend of what you say, the tea, milk, sugar, water, masala. That is what I am.
Okay.
Okay. Doctor for a patient, a teacher for a student, radiologist, researcher. At the same time, in radiologist, I am doing diagnostic radiology for diagnosing the disease.
Okay.
And I am an interventional radiologist and have a flair now for the AI.
Okay.
Okay, so that is what I am.
Okay. As you were told, you are in radiology.
Yeah.
So basically, if someone is watching this and don't know about radiology, what would you like to tell him about radiology and its importance nowadays?
So what you are trying to ask is direct application, but I would like to take you from the beginning a little bit of it, so that you'll understand. Like, unless and until we give equal importance to the history and the work that the people have done in this field, will not be able to do enough justification for the modern era application. So if you browse the net, you'll understand the first image that was taken was of a hand by Sir Wilhelm Röntgen on the 8th of November, which was Friday on 1895. And that was the X-ray of his wife.
Oh.
Because he has discovered accidentally there was some exposure and the plates had got changed, because of which he tried to use the hand. But it was not known which energy is it or which ray is it. So we say, who is that fellow? Maybe some XYZ. So that is what this came as. What is this ray? X-ray, an unknown ray. So likewise in 1971 CT scan came up, 1977 MRI came up. So what people think in common terms, if at all you have to explain to a common person, what we have to understand is, if he doesn't know anything, nothing about medical science, you can tell that he is a photographer in the medical field. That's just a small beginning, just what that Friday of 8th November had started with. Now it is way beyond it, and what we have is, we have these exemplary eyes in the form of machines where we can look into the body. Internal structure of the body, not just this thing. So बोलते हैं ना कि face reading कर रहे हैं, you are reading inside your body. Okay, so it is like in the field we use different techniques like X-ray हो गया, ultrasound हो गया. So these are those things where each and of every equipment has a different energy which is used. Like it was X-ray, but then if you see ultrasound, where we know commonly ultrasound is माता का पेट का स्कैन करना है क्योंकि बच्चे का अंदर का वेलबींग देखना है. So it is like for knowing the fetal well-being, we scan the mother, but at the same time X-rays are harmful, so you cannot damage the fetus. So we use ultrasound X-ray. So ultrasound rays, basically not the X-rays but ultrasound rays, which actually check what is happening inside the fetus or the mother's womb, how the fetus is. So So that was again a piezoelectric crystal was the first thing.
Okay.
So that is a piezoelectric crystal where it actually takes up electrical energy, creates vibrations, those vibrations are transmitted to the body, then the reflections are coming up and then you form an image. So the innovation or the invention which was there, somebody invents, Curie, Pierre Curie. She took that piezoelectric crystal. Somebody else as a mathematician, he has taken what image comes out. So these 2 or 3 people, they actually work together. Somebody is forming this, other is forming the computation, third one is a mathematician who makes those mathematical formula into the image. Now that is what we use for routine ultrasound scan. Now what is CT scan then? CT scan is nothing but the X-ray. That X-ray, which actually not a static tube, it is like this, is a normal X-ray. But when it happens that it rotates around the patient's body, you can actually have the look as to your ear from right side or left side, how does it appear.
Okay.
So it looks internally because we are cutting it with the form, in the form of a section, and that is what is tomography. But again X-ray. So you have to mind it is a harmful thing. But then comes something like MRI, which was initially put us by Lauterbur as nuclear magnetic resonance. And as nuclear magnetic resonance, we use certain nuclear properties at that of a nucleus of an atom, not just a nuclear this thing. So it becomes like a proton part of the nucleus is used, and we excite the body in the form of magnetic field, make it appear to be excitable, and once it is ready, we put some energy and the blood inside you or the bone inside you will respond differently. And that is how the image comes out different. So this is all which is coming up as modern era applications. But then we are seeing a photographer in this form of diagnostician. So we are trying to help those treating doctors as how the patient's disease is, whether it is there, how it will work, whether it will progress or whether it is static. But then it is just a diagnosis. But over a period of time we use the same imaging modalities, as we call it, to put a needle, to put a wire, to put a tube or to put a balloon. So that means we are trying to treat the patient by way of scalpeless technique, as we say. We do not cut upon the body through a small hole, we put different tubes and try to treat the patient by opening up the blocks or fixing up the leaks. Other than that, there are many things which can happen. It's a totally different scope of discussion. This branch is called interventional radiology. So that is where the radiologist stands in the modern era, from starting from a mere simple photograph of his wife to a diagnostic technology, and using that diagnostic technology even to treat patients with ultimate expertise, accuracy, without having any surgical need. So that is what it is.
एक्चुअली ये इतना सब आपने बताया, जो भी अभी इससे पहले मतलब रेडियोलॉजी के बारे में सुनता रहा होगा, कोई भी स्टूडेंट भी जो मेडिकल का नहीं है, उसको सिर्फ इतना पता था रेडियोलॉजी मतलब सीटी स्कैन, एक्सरे, स्कैन स्पेशलिस्ट, वही पता होता है। करेक्ट। हाँ, और ये भी जैसे कि आपने बताया एक्सरे का, तो ये भी पहले कोई भी बाहर से देखेगा तो उसको लगेगा कि बड़ा रिसर्च हुआ होगा, ये सडन अचानक ये
चेंज है। एट द सेम टाइम क्या है कि इसी में भी टेक्नोलॉजी, जैसे व्हाट वी आर ट्राइंग टू से is now the institutional radiologists, they don't stop at this point. They're actually having a lot of collaborations. They take out images, they find that there are some fine-tuned problems which are there which they cannot remove it, or which they want now. They are initially the CT scan was having only first, when I did a CT scan in 1997 for some patient during my studies or my residency. For a head, we used to take something like 18 to 20 images only. Now for a CT head, we are upon 1500 images.
Okay.
That is the technology which has evolved now. And now what will happen? I have to have that much of time, that much of people, so that I should be able to arrange those images in a desired manner and come out with a diagnosis. So now the institutional or sometimes even private people also there are collaborating with the technology guys to find some automations in this, or to some extent quantify this without having multiple episodes of loss of time for the same thing again and again. So that is what research is about going on. And on intervention side, we are trying to develop different products. Like some people develop their own needles, some people develop their own catheters. Because then these hardwares which are there for intervention radiology, they are costlier outside. So there are firms which are coming up with these things.
Okay. When you were a student, medical science student, and now you are leading this department, how has your definition of success in medical sciences evolved over the years? What was your vision actually when you have started this journey as a student and now you are the head of this department?
Yeah, that's a very difficult question to answer, and if I can borrow some comparison from the present generation,
okay.
It's like we keep on changing friends, you know. If I don't want to go on the quite different direction, but still we do have, the moment we change the institute, we keep on changing the friends. But it's similar to that, not exactly the same, but what happened is initially, as I said, the vision at that particular point of time, or it's more than the vision, during those days or that age, as you might also have, is a dream. It starts with a dream. And when you have a dream and you are serious about it, then you start envisioning it.
Yeah.
So what is my aim, or what will I do to achieve this? So that time it was like, I want to become a doctor, I want to become a surgeon, so that I fix up things then and there itself. Okay. At the same time, it's possible that if I want to do that, unless and until I diagnose it properly, so I want to do medicine properly. So there are different branches called as medicine, surgery, all this stuff. But then it was like I should do something in that direction. That time even I was not aware that radiology would be such great that moment when I entered into medicine. Only when we started seeing the patient, oh, patient is outside, he's just going in, coming out, but his internal thing is displayed. And that is what actually makes things more versatile. So over a period of time when it was like MBBS finished, then we came to MD, we finished in radiology. After that, it was like those days in radiology, I am actually in that bridging generation where I have seen the problems of the previous part and the start of the new era, and I am actually belonging to that, and for that I am really very lucky, if I can say it. But what happens, you know, those days it was like not all radiology departments were having these sorts of equipments in all institutions, nowhere. So if you have X-ray and ultrasound, they may not be a CT. Fortunately, I was in GMC Nagpur, Government Medical College Nagpur, where Dr. Kajal Mitra was my guide. There the CT scan was there, which was donated by World Health Organization. And I was lucky to have it there in Government Medical College. To have a CT scan those days was a very difficult task, but still we had it. We didn't have MRI or certain other things. So naturally after that, if I have to do something, so I have to spend at least 3 or 4 more years. And those teachers of mine in those days, we were lacking technology a little bit, but we had the support and push of all our teachers during our MD radiology. And they said, nothing doing, you should go to some places where they have all these things for at least 3-4 years. And somehow I landed up in Sri Chitra Medical Center in Trivandrum, where everything was there, and something which I had never thought was also there. So whatever interventional radiology, MRI, CT scan, advanced CT scan, all those stuff I started learning there. I started getting a master in that. At the same time, I started collaborating with my biomedical colleagues there, which actually gave me new food, so which I had never imagined. And that, working for 13 years in Sri Chitra, that actually changed my complete this thing, because for those 13 years I carried from there here. So first 3-4 years was spent in building up the department, but at the same time we had started collaborating with NIT Raipur. So we had some collaborations, some PhDs coming up here, and they are doing work. Similar thing which was happening in Trivandrum, I started continuing here. So the faculties of NIT Raipur and the support from AIIMS Raipur management. It was all a very good this thing. So now when I see it here, I didn't think, if I look back, whether I dreamt of this, no, I never. But as I said, as I kept on changing the institute for progress, I started having new friends and new toys of technology. And with the technology in between, what happened is suddenly that MRI changed in between, the technology had changed. And then suddenly, like, if you want to do MRI brain, fine, you do it. Brain is sitting idle. It cannot move to damage your image. But you cannot ask the heart to stop to get your image, you know. You stop for a second, I need to take your image. It doesn't happen. So what do you do then? You have to have MRI technology in such a way that it runs with the speed of the heart, so that the relative difference or the relative motion between the two is zero. So you get crisp, clear image, and that is called cardiac MR. So that is where I went for a 1-year fellowship to Germany during my Sri Chitra days, which was again given as an award by Ministry of Science and Technology. So there I learned that it is not just medicine that comes in, not just radiology, because they had a collaboration with Zurich Institute of Technology, the ETH from Switzerland. One of the mathematicians from other part of the Germany used to help me out. So whatever I was thinking, everything was getting fed, more manure was being put, so that crop was actually flourishing. That is not just medicine, we need medicine and technology both. So that is how I feel. I never thought about this, but it has come up like this, and now I feel that this is not enough. We need to do a lot more. And that is how I interact with the young guys like you from NIT, and they come for internship here. We start giving them some tasks and it comes out nicely.
एक्चुअली मैं भी यही सोचता हूँ कि जब आप स्टार्ट करते हो तो आप एक पोजीशन देखते हो, यहाँ तक पहुँचना है, लेकिन जब आप धीरे धीरे बढ़ते जाते हो तो फिर आपका गोल चेंज होता जाता है कि आपको वहाँ पहुँचने के बाद आप देखते हो कि क्या प्रॉब्लम है, फिर उसको कैसे सॉल्व करें। एक स्टेज के बाद आप अपने आप को देखना कम कर देते हो, फिर जब आप मतलब
अपना नहीं होता है, उसके बाद प्रॉब्लम होती है, प्रॉब्लम का सोल्यूशन होता है ना। करेक्ट, सही बोला आपने।
तो जैसे मान लीजिए अगर कोई पेशेंट आपके पास आता है और दूसरे हॉस्पिटल्स में उसने दिखाया और वहाँ के डॉक्टर्स ने मना कर दिया कि हाँ हमारे बस का नहीं है, आप दूसरी जगह पर जाओ, आपके पास आया, तो उस सिचुएशन में, हाई रिस्क वाली सिचुएशंस में या हाई स्टेक वाले इन्वायरमेंट में आप रिस्क कैलकुलेशन कैसे करते हो, कैसे अपने आप को काम रख के चीज़ें आगे बढ़ाते हो?
नहीं, अब मुझे थोड़ा सा इसमें क्लैरिफिकेशन चाहिए कि काम रख के मतलब क्या?
काम मतलब आपके पास, क्योंकि हाई रिस्क वाला आया कोई पेशेंट, हाँ, तो दिमाग में ये तो रहता है कि हाँ पेशेंट को बचाना है और रिस्क भी है उस पर, तो उस सिचुएशन पे प्रेशर भी फील होता होगा, तो उस सिचुएशन में आप अपने आप को कैसे मतलब मैनेज करते हो? हाउ डू यू मैनेज योरसेल्फ?
हाँ, सो ये थोड़ा सा अलग चीज़ है which has to be learned over as an experience and it comes only when you keep handling such situations again and again. ऐसा पहले ज़्यादा होता था, अभी क्या है कि बाहर भी अभी ट्रीटमेंट मोटा मोटी हो ही जाता है ना, बट द सिचुएशन इज देयर इज अ लिमिट, क्योंकि बाहर में क्या होता है कि रिस्क, देयर इज अ रीज़न दे वोंट टेक रिस्क टू मच बिकॉज ऑफ सर्टन रीजंस. एक तो द फाइनेंशियल दिस थिंग हैज़ अ डिफरेंट एंगल, एट द सेम टाइम द अफोर्डेबिलिटी ऑफ द पेशेंट for that type of treatment in a risky scenario, that is also different. And whether we like it or not, but there is a different sort of belief that trust takes a little longer time when financial angle is involved. So in such cases those patients come to institutes. So that means बाहर जो treat नहीं हो सकता है वो यहाँ पे आ रहा है. इसका मतलब ही ये हो जाता है कि it is called as a tertiary institute or tertiary care institute, where some treatments which were possible to be given outside are treated outside. जो बाहर possible नहीं वो यहाँ थे. अब जैसे उसी बच्चे का मैं अगर आपको एक बता रहा था, जब भी एक मरीज था, 1-1.5 साल का बच्चा होगा, कुछ टॉन्सिल के इसमें कुछ दिक्कत हो गई थी उसको, तो बाहर में किसी ने उसको उसके मवाद को निकालने के लिए एक नीडल लगाई. अब उसमें क्या हो गया कि उस मरीज़ में जैसे ही इस केस ऐसे केसेस में करते हैं तो नॉर्मल ही किया है उस डॉक्टर ने, बट उस मरीज़ में उसकी आर्टरी कहीं और से जा रही थी और वो टॉन्सिल को लग के जा रही थी, ये पहले से किसी को पता होना संभव नहीं है, तो उन्हें भी शायद पता नहीं होगा, तो उन्होंने उसको डाला, पर वो मवाद निकालते निकालते वो आर्टरी में भी लग गया। अब उसके कारण क्या हो गया कि वो पूरा ब्लीड होने लग गया, और ब्लीड होने के बाद फिर यहाँ पे जब आया पेशेंट, मरीज़ ले आए, तो उसको हमारे यहाँ के पीडियाट्रिक्स डिपार्टमेंट ने भी अच्छे से उसको मैनेज किया, ENT डिपार्टमेंट ने भी मैनेज किया, पर ऐसे जगह पे वो फट गया था कि जहाँ पे उसको सर्जरी करना संभव ही नहीं था। अगर वो आर्टरी को रिपेयर करना है तो वहाँ तक आर्टरी पकड़ना है, यहाँ से आर्टरी पकड़ना है, दोनों में जगह ही नहीं है। अब क्या है कि बाहर में वो ट्रीट नहीं हो सकता था, इसलिए यहाँ पे आया, और यहाँ पे भी जब दिक्कत होती है तो इस तरीके का जब प्रॉब्लम होता है तो ऐसे टाइम पे फिर प्रेशर ज़रूर बढ़ता है कि अभी बाकी तो कोई कुछ नहीं कर पा रहा है, तो जो भी करोगे आप करोगे, तो इसका मतलब दो होते हैं, हो गया अच्छा तो भी आप करोगे, और अच्छा नहीं हुआ तो भी उसकी रिस्पॉन्सिबिलिटी भी आपकी। थोड़ा प्रेशर होता है, बट देन यू हैव टू अंडरस्टैंड कि यू आर नाउ ट्राइंग टू गिव समथिंग टू द पेशेंट विच वॉज नॉट पॉसिबल एट ऑल। तो आपको काम रखने के लिए एक ही मोटिवेशन रहता है कि जो डिनोमिनेटर है वो शिफ्ट होके, जो पहले डिनोमिनेटर 5 था वो शिफ्ट होके अभी 0.1 तक आ गया है, 0 तो नहीं बोल सकते हैं, 0.1 तक आ गया है। तो आप उसके ऊपर कुछ भी करोगे तो न्यूमरेटर थोड़ा भी डाल दोगे तो पेशेंट के लिए वो अच्छा ही नंबर बाहर निकलेगा। तो दैट इज द ब्यूटी ऑफ टर्शियरी। जो बाहर नहीं कर पाते हैं वो अगर हम कर रहे हैं तो मरीज या मरीज के रिश्तेदार भी खुद इसी लेवल पे आए हैं कि बाहर नहीं हो, अगर हो पाया तो यहाँ हो पाएगा, नहीं हो पाएगा तो सच्ची में नहीं हो पाएगा। तो वही एक मोटिवेशन होता है, दैट इज व्हाट यू हैव टू कीप योर काम। पुराना जो अपना टेनासिटी है कि भाई नहीं हम तो करके दिखाएंगे, पेशेंट विद पेशेंट बेनिफिट इन माइंड, और उसमें फिर दूसरा कुछ नहीं दिखता है, देखना नहीं चाहिए, तभी सब ऊपर वाला सब आपके हाथों में सक्सेस देता है।
तो दैट इज, हाँ ये भी सही है। अपने देश में भी जैसे कि एम्स को बहुत ही ट्रस्टेड मेडिकल साइंस की तरीके ट्रीट किया जाता है। जब भी कोई भी यहाँ आता है तो उसको एक भरोसा रहता है कि हाँ वहाँ नहीं हुआ तो यहाँ होगा, तो यहीं होगा, नहीं तो फिर कहीं नहीं हो पाएगा। करेक्ट जी। तो जैसे कि एम्स रायपुर हैज़ इवॉल्व्ड रैपिडली एंड क्लाइंबिंग अप इन IRF। करेक्ट, यू हैव सीन इट थ्रू ईयर्स। Correct. According to your point of view, how it got transformed in academically and clinically over the years?
You're talking about NIRF ranking or the reason for NIRF ranking?
Both.
See, what happens is the initial this thing, as I told you regarding the infrastructure, the building started from unplastered wall. So you have to understand the patience of those students, where only part of that college was ready. And other part was under progress. They were also cooperative. They had also a much responsibility as well as a role to play in bringing up the name of the institute. Because these are those students where we had less in number, faculties were less in number, so we kept on having one-to-one interaction. And that is where they found that yes, whatever people these AIIMS have recruited as faculty from different institutes all over the country, these are good. And they would better listen to them and progress ahead. The same students kept on doing more better outside also. And these are the so-called ambassadors. When they go outside and say that yes, we have studied there, they go in a next institute where they do either MD or DM or whatever they are doing, and they are settled outside. And when they meet the new students, they say, okay, we have done it from here. So that is a cycle. The cycle comes up. And as it is, the moment that research keeps on happening, the research, the treatment, and a positive note that goes into the media from the institute that yes, this is what we are doing, only then people come to know. How did you come to know? You have browsed the net. Actually. When you browse the net, that is where these things come in. Okay, that is how our present ED also is telling about it. That you bring the positive vibes, let the media, let the people know about it, and that is when people, when they come to know that okay, that is how the rankings go up, that is how the patients. Actually, before COVID, what was happening, people used to come less. But then when they found, when the COVID started, what happened? The moment it was declared that COVID is there, most of the hospitals, not just in Raipur but other places also, they closed. Because of obvious reasons. They are not wrong in that. But then, by that time, the patients who had left their houses and had already come to the Raipur city, they had nowhere to go. So we were doing 100 X-rays before that per day, and that was the day when COVID happened, and COVID onwards, we are not doing anything below 600 X-rays a day. So that was the first day when it happened, 400 X-rays had to happen. That is how people came to know that this is the hospital. People from far-fetched this thing, where they know by word of mouth that okay, they have to go to this hospital, that hospital. They come, they go to that hospital, get treated, go back. But when everything is closed, that is when AIIMS Raipur came forward. That is how it came to know. And that is when you come to know that patients are there, different sorts of patients are there. That means that is a study material, whether we like it or not. But yes, by treating the patients, we are teaching the students on the same thing. That is, in a way, something called as a academic or a teaching content. And when that teaching content is there, enough teaching content is there, students will naturally come. So suppose every generation, the students start opting one by one. Previously it was like, let us assume it was number 6 in AIIMS, then it comes 5. So then that is how, when the patients increase, the type of treatment that goes on increasing, the, what do you say, more complex cases get treated, that is where the students opt for. Would you go to a place where you don't want to, don't get proper this thing? So that is how each counseling will change this ranking. And when that happens, how people opt for it, what sort of treatment is given, whether that treatment is applicable for the people around in that area, that is how it starts improving, and the NRF ranking also goes up. And this is cooperation of all the people around.
जी एक्चुअली हाँ, इस पे भी है, जैसे कि मैंने एक कवर किया था अपने प्रोफेसर सर के साथ, तो उन्होंने भी ऐसा कहा था कि अगर आप कुछ अच्छा कर रहे हो तो उसको लोगों तक पहुंचाना चाहिए कि हाँ आपने अच्छा किया, तो लोगों को पता चले कि हाँ अच्छा हुआ। जैसे जो भी यहाँ से स्टूडेंट पढ़ के गए वो जब बताते हैं तो वो क्रेडिबिलिटी और बढ़ाता है मेरे साथ जी।
They are the ambassadors.
हाँ जी। तो एक्चुअली लगभग आज के समय पे हमारा देश जो है वो इंटायरली क्यूरेटिव सिस्टम पे है कि जब पेशेंट, जब कोई बीमार पड़ेगा तब वो जाके मेडिसिन लेगा या डॉक्टर के पास जाएगा। तो हाउ कैन वी बिल्ड अ एनवायरनमेंट काइंड ऑफ preventive kind of system? So before getting sick, we go and treat ourselves, a kind of thing.
Correct. तो बीमार नहीं पड़े वो एक अलग क्या कहते हैं एंगल है लाइफ का, एंड दैट इज़ नॉट अबाउट समथिंग विच वी से दैट इट्स अ डिसीज. व्हेन यू से यू वांट टू ट्रीट, यू आर ऑलरेडी हैविंग सम सॉर्ट ऑफ डिसीज, इवन इफ इट इज अ स्मॉल वायरल फीवर. So like the scene what I was trying to tell, that during MBBS we have a subject called as Community and Family Medicine, it's called CFM, or also another name is Preventive and Social Medicine. We are taught different ways of how to deal with scenarios. Even how to treat a cholera or malaria is also some part of it when we are trying to tackle the disease in the community. But why do we get cholera? What is it? Are you aware of that? Cholera is something where you get loose motions, or you get malaria means you will get fever. But everybody knows that it is because of improper food hygiene or improper toilet habits or too many mosquitoes to get you transfer that malaria from someone else. So what is preventive medicine then? It is like you have to live in a healthy way, do not allow lot of water to be stagnant, or have proper food habits, clean your hands before and before the food or after your toilet. So these are those things which are called come in preventive medicine. At the same time, if you go a step further, these are those problems which I told are more towards the lower socioeconomic group. But for the affluent societies, what happens? People have a very sedentary lifestyle. I'm sitting here continuously, but I'm not taking care of my physical health. So I don't go for a walk, I don't do sports, because of which diabetes, hypertension. So we start taking medicines for that as a treatment. But if I would have been mobile, I know that my job is a sitting job, so it is my duty to respect my body, to take a proper sports activity or a physical activity at the end of the day or the start of the day, at least 45 minutes a day. Okay, but at the same time, what happens is, if the technology like AI also comes in and starts having a survey all around the society as well, with the help of the doctors, like what is a particular type of scenario without actually invading the body. What is the type of scenario, what is the background of the patient, or rather the subject, not a patient here. And those things, if you put in some AI tool and try to have a predictive thing that this patient or this sort of community with this sort of lifestyle is likely to have this much chances of this thing. So in that cases, we have to target those people to have more rigorous physical exercise. So that is where preventive comes in. At the same time, in radiology also, what is happening is we have something called as preventive radiology nowadays. And what is preventive radiology? Is basically we are trying to catch up with those people who are, we're trying to use our own ultrasound scans, trying to target those females who are pregnant but with a low socioeconomic group, their nutrition is not good. We try to do those things, try to give them some medicines or like folic acid or these things. So those are these things called as social responsibilities that a radiologist also does. So I am actually the president of the state chapter of Chhattisgarh here for Indian Radiology Association, where we are actually planning in a few days or weeks about Sanrakshan, and that is a preventive radiology. So whenever we have certain tools like bone mineral density, we try to do it with the X-ray or the BMD, that machine DEXA scan. We can actually predict whether this patient is about to have a fracture later in life or not. So we know that this happens mostly when the ladies, they finish their period, the menopause has started, and this is more likely to happen in those patients. So we try to target those population and try to see that we do not land up these ladies in more moribund situation. So starting from a small simple hand wash, a proper mask, to higher end scans also, the whole of preventive is actually geared up. But yes, we need to do more, wherein technology can help us a lot.
हाँ, इस पे टेक्नोलॉजी तो हेल्प कर ही सकती है और डॉक्टर्स अपनी तरफ से भी कर रहे हैं कोशिश, और उसके साथ साथ हम लोगों को भी, जो आम लोग हैं, जो उनको भी कुछ
लाइफस्टाइल चेंजेस नीड टू बी इम्प्लीमेंटेड. करेक्ट.
जी. तो जैसा कि एआई का हाइप बहुत सारा है, बहुत बातें चल रही हैं इस चीज़ पे.
करेक्ट.
तो मेडिकल साइंसेज में या हेल्थ केयर में ऐसी कौन सी चीज़ें हैं जो एआई ह्यूमन से बेहतर तरीके से कर सकता है, और कौन सी ऐसी चीज़ें हैं जहाँ पे एआई कम्प्लीटली फेल हो जाता है या नहीं कर सकता?
This is a slightly tricky question because if I see that I am the only doctor in the town and if AI comes in, the first response of a doctor is, ये तो मेरा job खा जाएगा. ठीक है. But what we have to understand is with the growing population, the population of the doctors is not increasing as much. हाँ, डॉक्टर्स बन रहे हैं, पहले 10 बनते थे, अभी 1000 बन रहे हैं. पर 10 के टाइम पे जो पॉपुलेशन 1 लाख थी, आज 1000 के टाइम पे पॉपुलेशन 20 करोड़ है. Isn't it? So that is where we have to understand. So yes, AI does help us, and that is where we want to tackle masses. When we know we want to filter कि masses हैं जहाँ पे हमको हर चीज़ में देखने की ज़रूरत नहीं है, ऐसे टाइम पे AI will definitely help us. We are not saying that we are failures. I would never say that. But at the same time, AI can be always used as a tool wherein we give more attention, focus my energy to those people who need maximally and most at that point of time. पर वो अगर नहीं दूंगा तो what will happen? The other people will start. I mean, if I keep my energy in those patients where they do not need anything. So that is where the AI algorithm can help in tackling the masses, tackling the common things and laying it on a platter. Okay. The other thing is, if you see the other way, even then the doctor has to see the patient because there is a legality associated to it. Even if you are coming to me and if I say that, okay, I see you after 2 hours because I have another patient, he will see you immediately within half a minute because this is an AI fellow, AI bot is there, he will look at you. You opt. If you are not knowing about what AI is, you will probably say yes for now, but at the same time, the moment you say he will not write treatment, you will say that, okay, forget about 2 hours, I'll wait for 3 hours, but see the doctor and then go.
Yes.
Okay? But if I want to take his help, what I will do is I'll instruct, give a prompt, find out what is it. I'll first address those things, ask what is his problem, and then I can tell, okay, what is a protocol number 1, treatment number 2, treatment number 3. If I tell, he'll just write the summary that's it. What sign I have to do? Because that is called as a legal validation. If that validation is not there, the treatment cannot be considered to be valid. And if the treatment is not valid, there are two things. One is the trust of the patient, and more so the legality, who will take the responsibility. Now also we have robotic surgeries as well. But that doesn't mean the robot does it entirely. Behind the robot, the surgeon is sitting somewhere else and he is actually manipulating that robot. But AI, what it does is, yes, if you say sometimes AI, what happens, it may not be a complete failure if you ask like that, but yes, it actually creates, sometimes confusions. It's like when we had a previous X-ray called conventional X-ray, and now we have digital X-rays. In between, initially what used to happen is with the digital X-rays, I have seen conventional X-rays also, digital X-rays also. But then digital X-rays used to show so many fine things which are not seen in convention. But then if there is a fracture, it will show it too much, even if it is not there. And I think that is a fracture. But convention will show fracture only when it is a fracture. But I still can't rely because the speed is not there. So these are certain things of technologies. So what will happen? AI will actually fail only in those cases where there is a validation. But it has to be a complete acceptance of both the technology partners as well as the healthcare workers. So if I have a queue of 500 people, and just to understand what I have to get it into my system, the AI will do that faster. And you can channelize those resources in the technical expertise in that. So it cannot be one replaces another, both have to go simultaneously. Okay.
So इसी पे थोड़ा सा आगे बढ़ाएं तो how much AI is reliable in healthcare?
Healthcare. Okay, so if I put it that way, this is actually from medical point of view, if I say, or if I talk it from patient point of view, there are two angles to it. So if it is from the patient point of view, initially I used to go to the doctor. If I have certain disease, I have found out one treatment has been prescribed, I am thinking that it's not suitable to my mind. So what I do, I put those things first in the Google, then I put what treatment has been given, then there will be certain things which will come up as confusions. I'll mug them up and then go to the next doctor with those questions. So that is how we doctors also used to tell, this is something like a Google patient. That is what is a terminology. When people do not know and do not trust or do not, but that is not something, this is just a lighter way of telling it. But what you do with AI is much more advanced, but at the same time, AI in healthcare is definitely come up in certain things as like manufacturing your equipments, like ventilators or this thing. So ventilators, monitors, this AI they are actually using in the factories to make use of those things to fine tune the final things. Like in ventilators or anesthesia ventilators where you give artificial respiration, it's like how much flow has gone in and how much has come out. That can be measured, but you have to simulate that if I put certain things in a patient having lung bad, having lung good, so those sorts of things will be simulated and they will be put from the other end. And that is when it will test without or long before putting it up in the patient. Okay. Now AI, if you say for radiology, in healthcare specifically radiology has become too much now, specifically because of the huge data. We deal with now so-called big data in radiology, and that is where, as I was telling you, in 90s when we were actually getting 20 images of a CT head, now we are getting somewhere close to 1500. That too only CT head. If I do a CT angio, it will be thrice this number. Okay, and if I have a CT for the chest and abdomen together because there is a big vessel running, that is where we call CT angiogram. So that is a slice of 0.6 mm or 1 mm from here till the pelvis. So you can understand this much length and 1 mm slices. You can imagine the huge data which is there. So what is happening is the scanners themselves nowadays are coming up with AI tools built in themselves, and that is where they'll give data immediately. The moment scan is acquired, immediately you'll get a 3D. How does it happen? So it starts accumulating, the images start coming. Initially we used to wait for some 3 or 4 minutes, now it comes immediately. But now if I tell you, there is something called full scan and half scan. Nowadays even if I do half scan, the AI algorithms are made in such a way that depending on those things which was actually taught to the system in deep technology by so many scans done before, that if I acquire this, I can actually build up this much. So naturally the time of acquisition of the data, speed of the data, both change. Immediately you will get the image. So that is where the technology driven situation is. Factory building up equipments, tools in radiology, they have come up. But again, as I said, validation becomes a problem, and that is the only thing. Otherwise AI is coming up in a real big way, and that is what is welcomed by the even medical people.
हाँ, उससे ये मुझे भी लगता है कि क्योंकि AI को अगर आप टूल की तरह यूज़ करोगे तो इट इज़ ओके, बट मतलब अगर कोई भी कॉम्प्लेक्स प्रॉब्लम है तो उसके लिए आपको एज अ इंस्ट्रक्टर तो रहना ही पड़ेगा, कंप्लीट उसका
something called as you call as a monitor. If the teacher is absent, it is like a monitor who monitors the class. That is how it is.
So sir, how will the role of radiologist change in next 10 years?
I think this is a tricky question. What you are trying to ask is a very sophisticated question, whether radiologists will exist or not. Isn't it? After 10 years in radiology, if you say that whether radiologists will be needed or not, only machines are enough, because now whole work will be done by AI. But I differ here that again you'll have those things, but AI will learn it from the data which has been fed to it, and each case for us even today is a new challenge. It looks like we have done 100 CT heads today, but still the challenge is same, that each CT head will have its own uniqueness which has to be dealt with experience point of view. But yes, if the AI has been trained to learn from its own data which gets built up day by day, it may be a problem for people who are again completely dependent on AI to write the reports, but not for them who use AI as their tool. You only have pointed it out in the previous thing, that if AI is used as a tool, but yes, because of the data which is there, which is huge, I think we can actually come up with more faster machines, with more stronger technology, so that we can acquire more images and different type of imaging modalities can come up. Basically AI can be used more of it in radiology for fusion of different images. Like for example, if I say the patient before surgery has undergone an MR, and during MRI we found out some disease. So during the surgery, the surgeon has put some implant in there. Now because the surgeon has put an implant, now I cannot do MRI again after that. So in that case we do a CT scan, but then with the help of AI we can fuse those images and try to see, even if I do a MRI today, a CT today, and later after implant I do only CT, I should be retro building of the MR image even without the actual performance of MRI. So that is where you say predictive modality, not just predictive information. Like you don't do a scan at all and still try to get image of that scan by using some other modality. So that is what I think, that is a good thing to do by technologies. Let us see how it goes.
Actually इससे क्या होगा मेरे हिसाब से, इससे भी एक्सपेंसिवनेस जो है मेडिकल फील्ड की,
वो भी कम हो जाएगा,
बार अगर
नहीं करना पड़ेगा,
वो कम हो जाएगी.
Correct.
Okay. So what skills should a medical student build so they are not completely replaced by AI? As we have talked about before that, you have said that will radiologists will be disappear in next. So what?
You mean to say medical students? See, if you are talking about a student who is just gone into medicine, like he is doing MBBS, if you say that there are people where Don't get into radiology, because radiology is now going to get disappeared. So you go into some other branch of medicine after MBBS. That is the very easy and a short-term solution that people might give you. But that's not all. Actual thing is, we have to understand that even if the phones have been there, yes, the cameras have disappeared. Because such good cameras have come up in the phones, dedicated cameras have disappeared. They are only for a few people which are there. Likewise, yes, if you do not want, not just radiology, it is like any branch of medicine, if you do everything with empathy, empathy cannot be given by the AI tool.
Actually,
That AI tool or a bot can go on talking robotically, the patient will sit there, he'll say, okay, he has told like this, and he'll go. But half of the times, the touch or the healing hand of the physician, that actually cures a lot of things. A psychological effect that cannot be ever given by AI. So the medical student should never forget that. And if he does that and gives all his sincerity in reading from the basic concept till this thing, not relying heavily on AI from the base itself. What happens nowadays, some people, even there may be students who actually, presentation in a class, will put it on ChatGPT and get it. There is no problem in that. You can do it. But do that only after you have read it and you tell the ChatGPT, instead of telling ChatGPT that I want a presentation on this, you tell the ChatGPT that yes, I have read these things, I just want to get these arranged in a particular manner. So menial work, manual work, whatever is there, give it to AI. Use that, save time to read something more or make the concept more strong. Otherwise, the slave will become the master.
Actually.
Correct? So that is what is for medicine in general. And that is true even for, and one more thing which has to be told for a medical student in healthcare, specifically when it comes to AI related apprehension, which is also applicable for the engineering students as well. If you see, the engineering students, when they want to go into engineering after the +2, they think I will not take biology. And it's the reverse on the other side, I will not take maths. Now there is nothing left like that. A person who deals with maths is a good physician, and a person who deals good with biology will become a good engineer. Previously they were miles apart, side. Now they have to come like this, and that is how the biomedical department comes in here. Where technology as well as the medical field, they overlap. And they will tell the IT, they will tell the CS what software, what sort of algorithm that has to be made, and what is the actual need. Without that, it can't work out. So do not find yourself as watertight compartments for subjects. Try to keep little bit of other things which you want to avoid, and you will go up very well.
Actually, India is great at software, MedTech, but we are still importing a lot of healthcare machines. तो क्या आपके हिसाब से लगता है कि आने वाले 10 सालों में इंडिया सेल्फ डिपेंडेंट हो सकता है इस मामले में? तो जो हम मशीन्स इंपोर्ट कर सकते हैं.
You are talking about the hardware part of it.
Hardware part.
Yeah, hardware part of it will actually. I should be asking you this question since you are from the technology, this thing. The reason being is whether it is a software made by you or a technology made by you or a hardware made by you, it is you who is doing it. Correct? Not the medical guy. I'm not saying that the responsibility is this way. So basically it is the tenacity of the person who wants to work in that mechanical field. Because that is where the entrepreneurship and the startups come in picture. Startups basically nowadays is only for software, where make startups and finish it off. But to get it relevantly transferred to technology and entrepreneurship, get it funded, make up a factory, make up those parts. Start small, start piece by piece, get all together. But yes, I am saying it's not doable. It is doable. The reason I am telling is we are already making it in India. If you know IIT Powai, there are certain firms in Odisha, some people are there in other states also, they are already making up all these things. Not just radiology, actually lot many machines are there which are being made in India itself. The only thing is people should get more stronger to do those works, because people want to do less work and gain profits fast. Here the minimum latent period which will be there, at least 4 or 5 years to get into a product. That much you should be able to withhold that problem. You know, if I don't do it, whether I'll become desperate. No. So I am actually appealing to my own friends in technology that yes, it should be done faster. But yes, not just do something, but with a proper standard to maintain. Just because we are doing it, we are not saying that the machines which are coming from abroad, they are better than ours. It's like planning and monitoring for any product development as well as product performance. That is more important, because if you don't do that, the product fails, the factory fails, and if the factory fails, it is a demotivator for other people who are trying to go in that field. So that should not happen. Don't say that fail ho gaya to sab khatam ho gaya. Perseverance should be there. So it can happen, but it's only like, if I say it can happen, for me to say and somebody else to do it, there's a huge gap which has been filled by the technology people.
Actually, अगर ऐसा होता है कि मैन्युफैक्चरिंग अगर इंडिया पे ठीक ठाक लेवल पे होती है और इंजीनियर्स और ये मेडिकल फील्ड के लोग
मिलके बनाएंगे तो ही वो जल्दी ये होगा, क्योंकि there are lot many people in medical field also, they don't want to go in that. Actually, when I was in Sri Chitra in Trivandrum, we were trying to, actually that concept was there, now they are actually making it. ये जो एक अनूरिज्म करके एक ये होता है, जैसे टीवार का एक ये बताए थे, एक स्टेंट ग्राफ्ट होता है. So that particular thing comes to around 3.5 lakhs, 4 lakhs, something of that sort. And in such cases, target was, let us make it in India itself. 25,000 में बन जाएगा, तो अफोर्डेबिलिटी कहीं के कहीं हो जाएगी. इंश्योरेंस भी अगर दे रहा है पैसा, तो इंश्योरेंस में 5 लाख देने के बजाय 25,000 देगा, he will sponsor it very easily.
Sir, you have seen hundreds of topper passing from this AIIMS Raipur. What is one non-academic quality which separate a brilliant student from a legendary doctor?
Okay, see, this particular thing which is there as a brilliant student, which will come up in other fields of courses also, not just in medicine. And that we try to say that if it is in engineering, it is an innovative thing, or trying to do something which is other than routine, that is another thing. But perseverance is common, correct? But in medical field, perseverance, if it is combined with compassion, आस्था जो मरीज के लिए होनी चाहिए, वो compassion अगर lacking है, तो you may be a good doctor, a good student, आपके पास knowledge बहुत है, और मरीज का ट्रीटमेंट जो है, मरीज को चॉइस दिया जाए, शायद आपके पास नहीं आएगा. अगर कंपैशन वाला डॉक्टर कोई बगल में है दूसरा, आपसे कम पढ़ा लिखा होगा, बट आपको अच्छे से ट्रीट करता है, डीलिंग अच्छी करता है, दैट इज व्हाट इज कॉल्ड कंपैशन इन एडिशन टू परसिवरेंस will be one key thing which makes a brilliant student a good doctor.
Medical training is like high stress, pressure and emotional exhaustion kind of thing. तो आप अपने स्टूडेंट्स को क्या सिखाते हो ताकि इन चीज़ों को भी वो बैलेंस करके रहे, प्रॉपर ट्रेनिंग वगैरह भी उसकी चलती रहे?
You're talking about the stress during studies. Now stress during studies is a part when it comes during MBBS. But stress during studies goes further more when you actually get into specialization. There you have two responsibilities. During MBBS it's only studies, but the moment you go into specialization like MD, MS or something, there you have to have an additional work thing, and that is called as either patient treatment, or in whichever branch you are, you'll have to deal with that as well. But as I told you initially also, that there has to be some sort of physical stress that you have to give it to your body, so that you de-stress yourself from the mental problems or so-called mental problems. And as somebody has already said, if you work, you'll definitely get stressed. But if you enjoy, you'll never get stressed. So whatever you do with complete involvement and enjoyment, you'll never get stressed. But yes, there are times we are human beings, so we have to have some physical this thing, as well as develop and nurture some hobby. If you have one, nurture it. It may be music, it may be just running around, jogging around, sweating around in the jogging, cycling. Somebody learns music, somebody sings, somebody performs on an instrument. That is how even I do it. Even I use musical instruments for my own this thing, de-stressing. I try to use my tabla for that. So now it's like long time has happened that I don't sleep on Sundays or Saturdays. I actually use this thing to de-stress myself.
Okay, sir.
Because that is something which is, whatever you want to stress, whatever stress comes during work, you have to de-stress, and that will come only when you do something outside your own medical field, and when you are doing it in the medical field, enjoy whatever you are doing. That will not let you stress at all.
Okay, sir. One last question.
Yeah.
If someone about 20-year-old young aspiring student or aspiring innovator is watching this, what is one single most important piece of advice you will leave for him?
Advice in what sense?
If a medical student is watching this, advice for his future, or if an innovator is watching this, advice for his innovation.
So this is what, I mean, I will have to borrow some quotes from somewhere else.
Okay.
From the Missile Man.
Okay.
And that's from his Wings of Fire, APJ Abul Kalam Azad, if you know. Be a medical student, be an engineering student, but you are a student of science. Okay. So if you are not, it may not be a single piece which I can say, but yes, this is a phrase what I can tell you. Perseverance, acceptance for failure, and still keep on doing things. So again it comes to perseverance. For getting answers to the question in the form of why, when, where and how. Try to answer these questions for anything which is happening, or any question is there, split that question into these 4 questions and then try to find answers for this. You'll innovate, you'll find things, you'll do things which have not been done before. So perseverance and acceptance to failure to find the answers to the questions of why, when, where and how in science. That will lead to success.
Indeed. Thank you so much, sir, for this incredible conversation.
Thank you.
So much.
I enjoyed it a lot. Thank you, Nikhil.
Thank you.